Welcome to today's lecture on wellness nutrition, and this is the introduction to Grodner's Nutritional Foundations and Clinical Applications. We're working in the 8th edition this semester. The concepts or the objectives of this first lesson or chapter is, first of all, we need to define health and wellness. We're going to describe what health promotion is. We're going to state the purpose of our Healthy People's 2030 initiative. We are going to talk about health literacy, identifying the 6 nutrient categories, and the functions of essential nutrients. First, let's discuss the actual role in wellness. And sometimes it seems too simple, and sometimes it's pretty difficult, right? Nourishing our bodies, really, we need to eat food. But then there's the complicating aspect of what type of food, how much food, how should this food be prepared, and asking ourselves, does the food we eat promote or maintain our health? Now, oftentimes you're going to hear all over social media, in your textbooks, patients, we're all talking about the best foods to eat. And which of the foods are best, particularly for nursing, we want to know which ones are the best during times of illness, specific illnesses, times of trauma. Things that we should start to consider is who actually is shopping for food? How much do people spend on food? Is there a difference between food and nourishment? Should we buy things that are ready-made, like ordering in food, Grubhub, Uber Eats? Should we make our meals ourselves? Should we get food delivery services where complete meals are cooked or maybe meal prepped? Should we cook from scratch? Should we eat alone? Should we eat with others? Who cleans after we cook? So in addition to just asking the questions about what are the best foods, there's so many other aspects to think about, especially when we're talking about the role in wellness and food nutrition with our patients. And the intent of this course and the nutrition textbook is really twofold. First, the authors are trying to educate about nutrients, foods, and related issues of personal health and wellness goals. But additionally, the focus here is to prepare you as a nursing professional to understand the function and the context of which there is a prescribed plan of care and how nutritional intervention is integrated in the prescribed plan of care. How do we use nutrition to prevent and treat disease? And are there things that we can do to alleviate symptoms that come from our understanding of nutrition? And are there things that actually could exacerbate patients' illnesses if we don't consider nutrition and food and how they complement or deter health? So this chapter is going to start with the question on just the concepts of health and wellness in general. The definition of health per the textbook is the merging and balancing of 5 physical and psychological dimensions of health. And these are things that we know: physical health, intellectual health, emotional health, social health, and spiritual health. Those merging and balancing components make up holistically health. Nutrition is the study of the essential nutrients and the processes by which nutrients are used by the body. When we say the word nutrient, we're talking about substances and foods that are required for our body for energy, for growth, for maintenance, and also repair. And some nutrients are essential, meaning our body can't function without it. And they cannot be made by the human body and must be provided by food. And because the primary role of our nutrients is to provide those building blocks for all the essential functions of our body and also the maintenance of these functions, nutrition is an overarching category of importance in meeting the 5 dimensions of health. And we'll start to unpack this in the upcoming slides. One more definition to know, the definition of wellness. And wellness really is a lifestyle that enhances our level of health. And in the past, health was just defined as the absence of disease or illness. But now that we know, we have more information, we have more research, we know that is far greater than that. One of the first expanded definitions of health was actually provided by the World Health Organization way back in 1946. And what they said was that health is a state of complete physical, mental, and social well-being, and not merely just the absence of disease and infirmity. And this is the perspective in which most of the nursing community refers to as health. However, although this definition addresses the concern that health is more than just the absence of disease, health is presented as a static concept that individuals need to achieve. So then, in 1968, a more expanded definition of health was presented by René Dubos. He was a biologist and philosopher who wrote, "Health is quality of life involving social, emotional, mental, spiritual, and biological fitness on the part of the individual, which results from the adaptation to the environment." And so this view actually expands this complex concept best represented by physical and psychological dimensions. There are 6 things to consider here with this model. We have physical health, and so the efficiency of our body to function appropriately, maintain immunity and disease, meet the daily energy requirements. Our intellectual health is the use of the intellectual abilities to learn and to adapt and to change in different environments. We have our emotional health, and that's the capacity to easily express or suppress our emotions appropriately. Our social health is the ability to interact with people in an acceptable manner, sustain relationships with our family or friends, colleagues. Spiritual health is our cultural beliefs that give purpose to human existence. These are found in faith, they're found in organized religions, they're found in the understanding of nature, science, or the acceptance of the humanistic view of life. And then lastly, our environmental health, which is related to the external factors that affect our health and well-being. This has to do with ourselves in a physical context within the places of work, the places we live, the places in which we interact. It's affected by determinants of our ethnicity, our education, income, occupation, and it does extend to a larger environment. And you're thinking about perhaps now like the social determinants of health. These are the factors that make up this environmental health. And this holistic view really incorporates many aspects of our own existence. And when we use the definition of health, it allows more individualized assessment of a patient's health status. Now, going back to then wellness, how does this fit in? Now, wellness is more of a pattern of behaviors that enhances the level of health. And really, it occurs as we develop each of the 6 dimensions of health that were previously mentioned. Now, when our patients, and ourselves included, are engaged in wellness lifestyles, we then will feel a sense of competency. We feel a sense of achievement, and we may even gain the ability to modify our behaviors to increase and further maintain positive levels of health. And we do have some things that can contradict or create barriers and impasses for this, like our schedules, especially as nursing students, and our work-life balance. But the aim is really to strive for wellness, even if it seems like we're constantly battling a series of barriers that make it more difficult. And then maybe we have times where we do a little bit better and we feel like we're really good and we're working towards our wellness, and then we might come back down again. And so, what the textbook likes to attribute this to is being like we're on a roller coaster. But the key is to renew those positive behaviors as soon as possible and to continue working forward towards our wellness. Now we're going to move on to health promotion, which consists of strategies used to increase our level of health. And this is and can be a broad term used to define health promotion with just individuals or families, groups, and even communities. And it is a three-pronged strategy. We need to first address knowledge, which is the learning of new information. For our patients, it's really trying to understand what are the risks of these health-related behaviors that we are participating in. The second one is techniques. Now, how do our patients apply this new knowledge to their everyday life? What they're doing, their activities, and how do they develop ways to modify their current lifestyle to improve their health? And then lastly, it's how the community is supportive of the changes that need to be made. And this has to do with the availability of environmental and regulatory measures that will support new health promoting behaviors within our community and a social context. So this is where Healthy People's 2030 comes in. And Healthy People's 2030 is a tool that replaces Healthy People 2020. And now we have new goals working on a framework that targets the here and the now, and really trying to understand, how does this really address the public health priorities? And so there are four things that we are hoping to achieve. First, we need to identify the needs in the priority populations. We are going to then, from this information, set the target goals. So we need to find the data that's related to this and see within the United States, what target areas do we need to focus on and what will contribute to national success. The third part of Healthy People's 2030 is to find inspiration and practical tools, things that our society and the people here in the United States can actually work towards and achieve their goal. And this is by exploring public health topics that are relevant for us to nursing and trying to figure out what are those successful programs, policies, and interventions that we can employ, all based on evidence-based research and practice. And lastly, is to monitor the national progress and use this information to achieve the benchmarks, to monitor improvement, and to see any gaps and where we can improve the health and the well-being of everyone here in the United States. So this is an opportunity to engage leadership, key constituents, and other public people, just in general, just the general public across multiple sectors. And we're trying to take action. We're trying to design policies that are going to benefit all communities. So part of nursing is treating the disease, but also preventing the disease. And disease prevention through nutrition is really recognizing the danger to our health that can be reduced or alleviated by specific interventions or actions like changes in lifestyle behaviors. And we also need to identify what hazards may be caused by a certain disease or a certain lifestyle choice or even our genetic factors. What about environmental threats? And areas that are not easily able to be changed depending on the person's social economic status, the location in which they live, and other cultural factors. But there are three classifications of disease prevention, which are important to understand. There's the primary, the secondary, and tertiary levels of disease prevention. And in the context of nutrition, disease prevention has very strong ties to nutrition overall. First, let's talk about primary prevention. And these are the activities that avert the initial development of the disease itself. So, for instance, eating a variety of foods that have um, balanced calories and nutrients. This is averting nutrient deficiencies. Trying to adopt a lower fat diet, high fiber or plant-based style of eating before diet-related health problems begin. This is primary prevention. So it's before we actually see a change in our health. Now, secondary prevention, this is involving the early detection. So let's say, for instance, you notice that your blood pressure is a little bit more elevated. Well, secondary prevention is going to halt or reduce the effects of the disease or the illness that's already in progress. And some diseases can't be prevented, but early detection can actually minimize negative health effects. Secondary prevention strategies are used to reduce chronic illnesses. Controlling the intake of certain nutrients can actually decrease the severity of some disorders. So think about diabetes, for instance. Once you are diagnosed with diabetes, making some changes related to the amount of carbohydrates or sugars that you consume can actually help to control or reduce the negative effects of the disease process. Now, tertiary prevention, this is after the disorder has developed, and really it's the sole purpose of tertiary prevention is to minimize further complications and try to restore health. And so these efforts involve not only changes in diet, but continued medical care, many interventions from interdisciplinary providers, and often it's learning more about the disorder itself to help the patients and the families to know what type of improvements or lifestyle changes need to happen. So tertiary prevention oftentimes will involve diet therapy. Direct treatments of many of the disorders that we will encounter in our healthcare career do have some dietary component. Give me some examples of this. Maybe someone that someone that you're taking care of is dealing with an ulcer or diverticulitis. So what they eat is going to affect their disease progression, whether it gets exacerbated or whether we can calm down the effects of their gastric ulcer or diverticulitis. Another example would be someone that has coronary artery disease, someone that again has diabetes. Other disorders that may affect food intake and the ability of our body to absorb nutrients also has to be looked at as well. So for instance, if you're taking care of a patient with cancer and they're undergoing chemotherapy, some of the side effects of chemotherapy are nausea, loss of appetite. So it's not only what they are eating, but possibly what they aren't eating as well, or the inability to consume enough nutrients. And therefore, nutrition counseling during these times, as an adjunct to their overall medical treatment plan, is really important. So, all examples of tertiary prevention. Health literacy is the ability to acquire, comprehend, communicate, and apply the basic health information and services, such as nutrition, and apply them to one's own health decisions. This is straight from the CDC in 2016. But how does health literacy develop in the first place? It's not the same thing as just putting, up printed word and giving out pamphlets. Health literacy develops through education on topics that are related to health promotion and illness. And this process of education occurs in three different forms: the formal, the non-formal, and the informal. Now, formal education is purposely planned for implementation in an educational setting, much like you being in nursing school. This is an example of formal education. Non-formal education takes place when there's some type of organized teaching and learning event, Think about a prenatal care class in a hospital or a hypertension class in a community clinic. And informal education, this encompasses a variety of educational experiences. Think of watching television, scrolling through your social media, reading an article, or browsing the internet. Now, health information from many sources becomes part of everybody's individual daily life and our overall database of knowledge. But some information is valid and some is partially true and some can be actually completely false. So our goal as healthcare providers is to ensure that health decisions are based on accurate information. And patients with low health literacy actually are more likely to visit the emergency room. Studies have shown that they are more likely to have hospital stays and extended hospital stays. They're less likely to follow treatment plans, and they actually will have higher mortality rates. So improving everyone's health literacy should be the goal. Now, you see that with the actualization of health literacy, so this is the ability to utilize what we are hearing and we're learning, and we are going to implement this to improve our health knowledge and improve our skills, has to do with four different factors. Our social factors, creating settings that are applicable and beneficial for learners to receive support for health promoting behaviors, but we also have individual factors. What are those choices that the person is making on an individual level day to day? What about cultural factors? Are there any cultural differences that encompass, and these cultural differences can encompass ethnic, religious, and racial health traditions? Are there any factors that we need to understand or be sensitive to help a patient meet their health literacy actualization? And then, of course, a supportive health system. And this is where we come in as healthcare professionals. Nutrients can be divided into 6 different nutrient categories, and we're probably familiar with these categories. We have carbohydrates. An example of that would be glucose. That would provide nutrients like carbohydrates. A source of lipids would be linoleic acid. A source of protein could be any of the amino acids. Think chicken, think beef or fish. Vitamins, we divide them into fat soluble versus water soluble. We have vitamin A, D, E, and K are fat soluble vitamins. And our water soluble vitamins, some of them are thiamine, riboflavin, B6, B12, folate, vitamin C, niacin, pantothenic acid, and biotin. When we think about our minerals, we have our major minerals and we have our trace minerals. Major minerals could be calcium, phosphorus, sodium, potassium, sulfur, chloride, magnesium. Our trace minerals are chromium, cobalt, copper, fluorine, iodine, iron, manganese, selenium, and zinc. And of course, our water is H2O. Now think about a food, for instance, and how we categorize a specific food. Usually it's based on what nutrient category makes up the majority of that food. So for instance, with this bagel, when we think of a bagel, we think of it as a carbohydrate because it's mostly containing complex carbohydrates, but it also contains protein, it contains water, amounts of vitamins, very small amounts of vitamins and minerals, and it even has a smaller amount of lipids and fats. However, we would consider this to be a carbohydrate in terms of the category of food, again, because of the carbohydrate content in relationship to the rest of the nutrients. One of the essential functions of a nutrient for our body is to provide energy. So let's consider the energy containing nutrients of carbs, proteins, and lipids. Why do they contain energy? Well, they contain energy because they're organic, and what makes them an organic compound is because they consist of hydrogen, oxygen, and carbon. When nutrients are oxidized, meaning they're burned in our body, then energy is released as a result. And when the energy is released, it's available for our cells to use. Now, although vitamins are also considered organic, they don't provide energy for the body. So it's only the carbohydrates, the proteins, and lipids, which are energy yielding nutrients. The energy that's released from food is measured. And how is it measured? In calories, or we call them kilocalories. Technically, a calorie is the amount of heat that's necessary to raise the temperature of a gram of water by 1 degree Celsius or 0.8 degrees Fahrenheit. So when someone asks you how much energy is an 8-ounce glass of skim milk, the correct response is actually 90,000 calories, or we say 90 kilocalories. But because we try to simplify this for, of course, numeric simplicity, we will just refer to calories instead of saying kilocalories. But really, understanding the conversion of calories and kilocalories, we're really talking about kilocalories. Okay, so when someone says, oh, this dessert only is 100 calories, what they're really saying is it's 100 kilocalories. If they were really talking about calories, it would actually be 100,000 calories. And if you saw anything that said 100,000 calories, you probably wouldn't eat that because of the misnomer of how we use that terminology. Now that we know that the actual terminology for energy released from food is a kilocalorie, let's look at the kilocalorie value per gram of each nutrient. So with every carbohydrate or protein for every gram, there is 4 kilocalories of value. Lipids, there's 9 kilocalorie value per every gram of fat, and there's 7 kilocalorie value per every gram of alcohol. Carbohydrates are a major source of fuel in our body, and we usually divide them into 2 categories, simple versus complex carbohydrates. When we think of complex carbohydrates, we think of starch and fiber. So we find these in cereals, grains, fruits, and veggies. With simple carbohydrates, we think of sugar, found in fruits, milk, and even sweeteners. Notice that one of these types of foods or examples are found in both the simple and the complex carbohydrate categories. Now, all of these things, except for dietary fiber, are broken down into units of glucose, and glucose is the most efficient form of energy for our body. Now, fiber doesn't break down very well by the human digestive system, and therefore it provides little energy. However, we still need to consume fiber because it's good for our digestive and absorptive systems of the body. The effects of not having enough fiber in our body ranges from constipation and even reducing the risk of colon cancer and heart disease. So though it doesn't provide energy like our sugars, fiber is still very important. Now, proteins, in addition to providing energy, also do much more extensive functions in the body. So some of these things include having a role in how our bones are structured, our muscles, enzymes, hormones, blood, the immune system, and just overall the cell membranes. When we link amino acids in various combinations, they then form what we know as proteins. And there are 20 amino acids that are required to create all the necessary proteins to maintain our lives. And some amino acids, they're formed by our body, and others are called essential amino acids, and they have to be consumed in the foods that we eat. So what are 9 essential amino acids? They're found in animals and plant sources. So think about meat, fish, poultry, some dairy products, milk and cheeses. We have plant sources that provide proteins like grains, legumes, so those are peas and beans. They also contain proteins, these peas and beans. We also have seeds, nuts, and many vegetables, although in very small amounts. And although we know that protein is important, eating too much can also become a problem. If we eat a substantially increased amount than what is recommended, it doesn't really make us a superhuman, but also it can cause our physical body to feel and be overworked, and the systems can be overworked because excess protein needs to be broken down to amino acids and then used for energy or broken down further into metabolic processes so we can store them in our body or so that we can excrete them through the kidneys and the urine. So again, consider the consumption of excess protein as well. Lipids are the densest form of energy available in foods. You saw 9 kilograms per gram. Fats or lipids, they serve other purposes as well, like being a component of the cell structure. They play a role in hormonal production. They provide padding to protect our body organs. Essential fatty acids and the fat-soluble vitamins like ADEK, A, D, E, and K, they're found in food lipids. Really, what makes our food taste so good is the amount of fat within it, most often. Now, lipids are divided into 3 categories. We have triglycerides, phospholipids, and sterols. And within the triglyceride umbrella, triglycerides can be saturated, monounsaturated, or polyunsaturated. And really, it is according to the types of fatty acids that each of these lipids or triglycerides contain. Now, fatty acids are carbon chains, and they have different lengths and degrees of hydrogen saturation. The most common phospholipid is lecithin. Among the sterols, we hear most about cholesterol or cholesterol. Although we consume a lot of cholesterol and lecithin in our food, our body also has the ability to manufacture these types of lipids on their own. Now, we often hear about how fat and cholesterol are bad for our body. Saturated fats or triglycerides that are found in a lot of foods often make headlines. Trans fats from processed foods, dietary cholesterols, these all are associated with increased lipid levels, right? So fat levels. We call this lipidemia. We have increased lipid levels in the blood. Now, elevations of blood lipid, whether it's formed naturally by our bodies or we've consumed it in dietary sources, really make up a risk factor for developing coronary artery disease. And this is why it's often talked about in research. Saturated fats, to a certain extent, even the polyunsaturated fats have been associated with an increased risk for certain types of cancers. So, do we know that coronary artery disease and cancers are a public health risk? Absolutely. And they affect millions of people in the US. Consequently, medical and health professionals emphasize the need to consume better types of fat and to moderate the amounts of dietary cholesterol that we put into our body. So again, that relationship between consumption of lipids and risk for the diet-related diseases has to be evaluated. Now, vitamins are compounds that indirectly assist the other nutrients. They're helpers, and they assist through the process of digestion, absorption, metabolism, and excretion. And there are 13 vitamins that our body needs, and they all have a specific function. You need every single one of them. And like we talked about earlier, vitamins don't provide energy, but they assist in the release of energy from carbs, lipids, and proteins. So without vitamins, the carbs, lipids, and proteins would not be able to release energy. And our vitamins, again, they are divided into 2 classes. We talked about the water soluble and the fat soluble. They're found in many foods, fruits and veggies. They're actually really great choices for consuming vitamins. And some foods are better sources of vitamins than others. Some have more of one specific vitamin than another. And so eating a variety of foods is the best way to consume the sufficient amounts of fat-soluble and water-soluble vitamins necessary. So just as a review, the fat-soluble vitamins are ADEK, vitamins A, D, E, and K, and the water-soluble vitamins are the B vitamins like thiamine, niacin, riboflavin, folate, cobalamin, which is B12, pyridoxine, which is B6, pantothenic acid, and biotin. And we also have vitamin C. Our body also needs minerals because they serve structural purposes in our body. They're found in our body fluids. Minerals in the body, they actually affect the nature of these fluids. Think of, again, about electrolytes. The 16 essential minerals are divided into two categories. We have the major and the trace minerals. The distinction is based on the quantity of minerals that are required by the body, but they're all important. So where do we find these minerals? They're actually plentiful in fruits, vegetables, dairy products, meats, legumes. We know that minerals are indestructible, but some may be lost through food processing. This is why whole foods are a better way to consume minerals. Think about whole wheat flour. When it's processed or refined to become a white flour, we lose phosphorus and potassium, and they aren't replaced in that process. Overall, we're doing a better job at consuming more water nationally. We understand that water is a major part of every cell, tissue, and organ in our body, and we can't go many days without water. It's a functional fluid that supports substances to help them break down and to be used in our body. It's a constituent, a major constituent of water, of blood, and it provides a means of transportation for nutrients to and from our cells, organs to organs. And many of us, though knowing this, we still don't drink enough water. Just a rule of thumb, you try to drink half your body weight in pounds and ounces of water. So for instance, if you're 100 pounds, you try to meet the goal of 50 ounces of water. If you're 200 pounds, you try to drink at least 100 ounces of water. The textbook tells you that about 9 to 13 cups of water a day, this is coming from the National Research Council, is their recommendation. Although this awareness and the value of water consumption is growing, and partially because we have great marketers like Stanley, Yeti, we have Hydro Flask and other water bottle companies, such as the way they bottle waters, and it has been a better alternative and a cooler alternative to other beverages that are out there, and they have become more convenient over time. Now, we do have to consider that in our public water supply in the past, they have put some vitamins and minerals in there. And we have water bottle companies that are putting vitamins and minerals and herbs, which are not always necessary. So overall, unflavored plain water is a better option in most cases. This term dietary standards is a guide to adequate nutrient intake levels against which we compare nutrient values of foods that are consumed. And so when we think about the dietary standards, it's providing a bridge between the knowledge of essential nutrients and how we consume our food. Okay, hang with me for a few more slides. We're going to talk about the dietary reference intakes. And in the US, in the past, these dietary standards were based on providing references of nutrients and the amounts that we would need to prevent nutritional deficiency diseases. But now it's not just the nutritional deficiency diseases that we're considering, but also what are the reference intakes that we need to reduce the risk of chronic diet-related diseases like coronary artery disease, cancer, osteoporosis, etc. And the DRIs also are considering the availability of the nutrients, the food components, and the use of dietary supplements in conjunction. And the responsibility to monitor, to change, to create these dietary standards really lies with the Standing Committee on Scientific Evaluation of Dietary Reference Intakes of the Food and Nutrition Board, the Institute of Medicine, the National Academy of Sciences, along with participation with Health Canada. So these recommendations now are not just for the US, but also Canada too. So North American. The DRIs, or the dietary reference intakes, are based on first reviewing the available scientific data about that specific nutrient, assessing the function of the nutrients to reduce the risk of chronic diseases and other conditions, and evaluating the current data on nutrient consumption in the US and Canada, so within the population. There's lots of lingo to learn in terms of dietary reference intakes. We know that the DRIs consist of the estimated average requirement, the recommended dietary allowance, the adequate intake, the tolerable upper intake level, meaning like the maximum, and the acceptable macronutrient distribution. So let's learn this lingo. The estimated average requirement, or the EAR, this is the amount of nutrients that are needed to meet the basic requirements of half the individuals in a specific group or population. The EAR considers things like deficiency and physiologic function. A public health official and policymakers, they primarily use the EARs to determine the basis for setting the recommended daily allowance, which is our next word or acronym, the RDA. The RDA is a level of nutrient intake that's sufficient to meet the needs of almost all healthy individuals of a life stage and a gender group. And the aim to this is to supply adequate nutrient intake to decrease the risk of chronic disease. But the RDA is based on the EARs for that nutrient, plus an additional amount to provide for the particular need of each group. Adequate intake, or AI, is the approximate level of an average nutrient intake determined by observation of an experimentation with a particular group or population, and then it appears to maintain good health within this population. The adequate intake is used when there are insufficient data to provide the RDA. The UL, or the tolerable upper intake level, is the level of nutrient intake that should not be exceeded to prevent adverse health risks. So the amount includes the total consumption from foods, from fortified foods, and supplements. The UL, or the tolerable upper intake level, is not a recommendation of the level of intake, but a safety boundary for total consumption. And there's not a UL for everything, but for the nutrients in which adverse risks are known. And then lastly, we have the AMDRs, and these are acceptable macronutrient distribution ranges, which are daily percentage energy intake values for the macronutrients like fat, carbs, and proteins. And for these energy yielding nutrients, remember those are only the fat, carbs, and proteins, the following daily intake ranges are set to provide adequate energy and nutrients while offering reduced risks of chronic disorders. So for instance, 45 to 65% of kilocalories should come from carbohydrates. It is recommended by the AMDR that 20 to 35% of kilocalories come from fat and 10 to 35% of kilocalories come from protein. In general, the DRIs, or the dietary reference intakes, are designed to meet the needs of most healthy individuals. And individuals generally use the RDAs and the AIs when they're assessing their nutrient intakes. However, people with special needs, nutritional needs, like those that are suffering from a particular disease, injury, or medical condition, they may have nutrient needs that are higher than the DRIs. And this is what this semester will be focusing on, what actually needs to be the alteration when we're working with clients and patients with specific disease processes. So again, these are just reference intakes. These dietary reference intakes are used to plan for large groups. They are used to create dietary standards for governmental food assistance programs. They also help to interpret food consumption information on specific individuals and populations. And these DRIs, dietary reference intakes, are used to develop new food products and to make imitation food products. There are additional things to consider. We have the EER, which is the estimated energy requirement. And this is a DRI for dietary energy intake. And the EER aims to maintain good health because it's providing energy intake levels that are appropriate now to an individual's body weight, specific to their age, gender, height, weight, and physical activity categories. We also know that we have global standards as well. And so other countries have developed dietary standards based on energy needs, food supply, and environmental factors that affect their particular populations. So in addition, organizations such as the Food and Agricultural Organization of the United Nations, along with the World Health Organization, have developed their own dietary standards that meet the practical needs of healthy adults worldwide. It is recommended that having an adequate eating pattern really is incorporating an assortment of foods instead of eating the same foods every single day. And it has been shown that though convenient, eating an assortment of foods instead of having the same thing every day over a 5-day period has actually shown that the daily average of fewer calories are being consumed and you will have a greater variety of nutrients. And this data is from the US Department of Agriculture. So knowing what the DRIs are will help make nutrition very simple, but not really. Mathematically, it seems simple, but by just eating enough of the DRI nutrients and trying to conform to all the numerical values isn't enough to ensure good health. However, we don't eat nutrients, we eat food. We're not thinking about the numbers of every single macronutrient every single day. Well, at least not most people. They're just eating food. So having an eating pattern and having an eating pattern that is considered adequate really has to do with having all the essential nutrients, the fibers, the energy, and thinking about assortment of foods, the balance of the foods, and how nutrient dense each of the foods are that you are consuming. So a good strategy to adopt is to be in the habit of selecting different foods for lunch, or at least rotating your food choices throughout the week. 3 other terms that we need to think about now that we are transitioning to the imbalance of dietary intake is the term undernutrition, overnutrition, and malnutrition. And there are estimates of food consumption that are used to determine nutritional status of individuals and population, but nutritional intake is sometimes imbalanced or your patient is undergoing a period of overnutrition, undernutrition, or malnutrition that can be diagnosed. And undernutrition is when you are consuming lower than the recommended amount of DRI to provide enough energy for your body. And so you may be eating enough food, but you're not getting the essential nutrients, or you're eating enough food for energy, but you're choosing foods that lack certain nutrients. In the US, women do not consume enough folate. And this is really important, we know, because it has to do with or not having enough folate can increase the risk of spina bifida during pregnancy. And so this is why folate has been put into prenatal vitamins. It's very important during these childbearing years. Now, overnutrition, on the other hand, this is consuming too much nutrients and too much energy compared with the DRI values. And here in the US, we consume too many saturated fats, which is the risk of heart disease. Malnutrition is a result of an imbalanced nutrient consumption or energy intake. And malnutrition is both undernutrition and overnutrition. So we can consume too few or too much of these energy producing foods. And we could also have excess nutrients of these energy producing foods. So think of a man with a BMI showing that he's obese, consuming an excessive amount of kilocalories of nourishment in 1 week. Right? He may have excessive calories and he's not getting enough enough nourishment because he's not choosing the foods that are balanced with the nutrients that are needed. So his intake does not equal the energy output. We call this also a nutrient overdose, which is malnutrition. So think of a college student who is constantly active in sports and really worried about their diet. They're consuming less now than the recommended or the DRI, the dietary intake, for nutrients and energy. So this can also be a form of malnourishment. Achieving wellness is an ongoing process for our patients, and we really need to consider that they may need help with meeting their personal dietary goals. Sometimes it's easier than other times. We talked about that roller coaster. And sometimes they feel a sense of control, and other times it's very difficult to regain that sense of control. So these ups and downs are part of this process of achieving wellness. And it is our job to help support their pathway toward achieving wellness. And we will be talking about in more detail the psychosocial strategies that should help our patients enhance positive self-efficacy. That term self-efficacy, this is the perception of our own ability to have power to do something in our lives and to change our behavior. And promoting positive self-efficacy means that this patient, or you are trying to help this patient to believe that their personal behaviors can actually be changed and that they have control over these choices. When we use the term negative self-efficacy, this is the feeling when our patient feels powerless with no control over their circumstances. And having this sense of positive self-efficacy is essential to attaining and maintaining nutritional lifestyles for optimum health, for obvious reasons. And so when we have a patient that has a negative self-efficacy, it is oftentimes more difficult to help them along towards a positive nutrition lifestyle. So there has to be some changes within their ability to see that they can have control over their situation. So these strategies may be applicable in our own lives as well. They're useful for our patients for sure. And overarching, we're trying to strive for enhanced self-efficacy.